consensus methodologies. I have nothing to declare in terms of conflict of interest. So, first of all, what is the methodology group and why we need a methodology group into the ESICM? So the methodology group is responsible for providing methodological expertise and the standardization, which is very important, into the guidelines of the ESICM. We are also in charge of some educational activity about that. And it is important because there are international standards that should be met when writing a guideline and a meta-analysis and so on. So specifically, if you want to have guidelines from a society, you need to meet these standards. And this is why you need a methodology group of people which is dedicated, which interact among them, and which try to meet these standards and try to be at the level of these standards. So this is the structure of the methodology group. There is Daniele Paul, which is the chair, and which is our authority when we need to consult, because he was in charge of several other guidelines in the past, for example, the last one, the ARDS, and several others. And then there are 4 groups with senior methodologists, and each of one is aided by 1, 2 or more junior methodologists. For example, I was aided in this consensus by Dr. Marzia Savi and Dr. Giacomo Coppalini from Humanitas Research Hospital, which I want to thank. These are the steps summarized of a guideline. So you start from the definition of study groups and chairs of each group. So generally you divide your whole topic in several subgroups, and then you choose some chairs, and this is something that the society do. And then you start from the definition of research question. You can have formal PICOs and research questions that are not going through formal PICOs. For example, if I want to have the definition of the shock, I don't need a formal PICO for that. So it is a research question without a PICO. In all these, before arriving at the consensus and at the final recommendation, the methodology groups is in charge of these red parts. So we help with the definition of formal PICOs. The research questions are proposed by the experts, by the chairs and by the experts, and then we help in providing a good PICOs, which can be used in the search. And PICO, of course, means a research question that takes into account a population, an intervention, a control, and an outcome. And if I want to look at several outcomes, they are actually several different PICOs. Then we have the systematic literature search, which is something in which we provide the research query reproducible, and then we can help in the systematic search, and we do the data extraction, and of course we do the grading of the evidence, which is one of the most important steps according to international guidelines on how to do international guidelines. All these arrives at the end into the consensus among experts, and then we arrive to the formulation of the recommendation. This is where we came from. We had in 2007 the first consensus on shock, which was developed by a panel of experts from 5 critical care societies. And in 2014, there was the consensus on circulatory shock and hemodynamic monitoring by the task force by the ESICM, and which we are updating this last consensus. Here, I want to talk mainly about the difference, methodological difference that we had. In the 2014 consensus, we had an international team of 12 experts in the field of shock. There were 4 types of statements which were produced: statements of facts, recommendations, best practice, and definition, for example, the definition of shock. In that case, the grade evaluation was not formally conducted, even if the grade was taken into account when providing the statements. So, for example, there were 2 levels of recommendation, strong and weak recommendations. But there was no formal grade evaluation. In this case, however, we decided to use a different approach, which is the one that is now recommended for international guidelines. And so there is the involvement of the methodology group into this consensus, and we use the GRADE approach. The GRADE stands for Grading of Recommendation Assessment, Development, and Evaluation, which is the gold standard, which summarizes the evidence according to an intervention across the literature provided. Of course, we use other tools, for example, for risk of bias evaluation. We use the ROB2 tools for the randomized controlled trials provided by Cochrane collaboration. The ROB-INSIGHT tool for observational studies. And on that, we were particularly, we wanted particularly to include studies with a high quality level if they were observational, generally with multivariable analysis included, and to avoid very small studies, retrospective studies with clear methodological flows. And then we use the QuadraStew tools, which is the one for quality assessment of diagnostic accuracy studies. All these for bias included in quality evaluation. And then is the grade evaluation. You know that there are 4 final grades, high, moderate, low, and very low. I just remind you the process to arrive there. We start with high quality or low quality studies, more generally 2 categories. Randomized studies are high quality as initial certainty of evidence, and non-randomized studies are classified as low. But then can be upgraded or downgraded according to several domains. So if they have a high risk of bias, according to the tools we have just seen, they are downgraded so from high to moderate and so on. Then there is the inconsistency problems, which is similar to heterogeneity. So if studies takes into account very different population or different population, for example, septic shock or cardiac arrest or trauma, these are differences. Or if we have different thresholds, this is another problem. And then we have problems with imprecision, so the awareness of the confidence interval, and problems of indirectness. So when we use a indirect marker like lactate or others to be able to derive clinical outcomes. And then we have something like dose response. If you have dose response effect, a large effect, and so on, you can upgrade your level of evidence. These are the 4 panels that already the chairman mentioned. So Xavier Monet for the monodynamic monitoring and also for leading the world consensus process. Michel Chu for cardiac ultrasonography, Antonio Messina for fluid therapy, and Jan Becker for shock diagnosis. So these are the 4 panels. Here I would just want to show you the PICOs. Not all actually are PICOs. Here are the first 2 groups, and then the other 2 in the next slide. Only the green one, which I marked in green, were underwent actually a full PICO, full grade evaluation with a full PICO, formal PICO. All the others, so the red one, were not included a priori as formal PICOs because the expert with the methodology groups considered this question as something that could not be answered by literature research, but mainly by something like expert opinion or physiological reasoning and so on. For example, shock definition cannot be answered by a formal PICO. This is for the other 2 topics. Again, on cardiac ultrasonography, we have 2 topics which underwent formal PICOs and another topic which was on mediated therapeutic impact of echocardiography, which is not. And the same for fluid therapy from Professor Messina. So we took all the PICOs and we started the systematic search. How we do that? We focused on PubMed and Medline, and we included mainly articles published less than 30 years ago and which were English. So this can be viewed as a limitation because sometimes in some systematic review you have to look at several databases, including Scopus and Bayes and so on. But here with Daniele Poole, we decided to concentrate on PubMed and Medline, which is the main database in medical literature. And also we decided to exclude the article according to this criteria. Also, it's not mentioned here, but I want to mention that we wanted to look at patients with shock. So we are excluding studies in intraoperative study with fluid assessment, for example, in patients which are completely stable undergoing cholecystectomy. This is not our topic. We want to talk about shock. So we are including only shock patients. This is the results of the systematic search. So we went to about 13,000 articles, which we are screening at title of abstract levels. We tried to be as sensitive as possible. Some questions were more prolific than others. For example, fluid therapy provided about 7,000 articles, echocardiography and 1,800 articles, and so on. And at the end, we arrived at 13,000 articles, which provided at the end, we decided to screen about 750 full-text articles, which were then screened, and about 100 were included into the final evaluation for the hemodynamic consensus. Of course, we had to use some collaborative tool. One was the Ryan, and one was the EPI reviewer tool to be able to do all these within the methodological group. So I just want to mention that. The EPI reviewer is one from the Cochrane, suggested also from the Cochrane collaboration, and they help us into doing the systematic review and the first part of these stages. And the last two slides, actually, I will leave the chairs to present the evidence of each PICON and to present the statements, of course. Just want to mention generally what we found. We concentrated mainly on main relevant clinical outcomes, for example, mortality and organ dysfunction in this phase of the consensus, because we have to start from that. We have to start from main clinical outcomes if we want to talk to clinicians in the world. As we know, the evidence in any case at the end of the extraction was not so high on this topic. There was often heterogeneity due to imprecision and again inconsistency across different trials with a difference in clinical types of patient included and intervention and so on. And often some of these studies were underpowered to detect, for example, mortality difference. So in the end, some of the recommendations that we present today will be based on the GRADE approach, while others will be included as best practice statements. Some of these a priori, as I mentioned, the red one in the table are presented as priori as best practice statements or expert recommendations, and others were presented like this because there is no clear evidence on that, but there is some strong physiological reasoning behind that. And so we can say that with Altman, to cite Altman, absence of evidence is not evidence of absence. And so we can in any case make a recommendation on that based on strong physiological reasoning and on the and on this type of reasoning and secondary outcomes, we can say. So for the final slide, I want to mention again, something which is very important from a methodological aspect and point of view, which is the problem of heterogeneity between studies. We can have several types of heterogeneity, which we have to take into account into our analysis and into our statements. There is clinical heterogeneity, for example, when we want to put together different type of patient, but also different type of intervention. For example, we can speak about high map and low map, but what are the targets and so on. Maybe they're different among different studies. We can talk about methodological heterogeneity. So, for example, a difference in risk of bias, difference in sample size, and so on. And then we can talk about statistical heterogeneity with high square and tau square, which measure the heterogeneity and inconsistency on one side, and also on meta-analysis, random effect meta-analysis, the type of difference between the effect of each studies. Okay, and with this I want to thank you all the participants of these for the collaborative effort and the chairs. Thank you.
Massimiliano, thank you for a very nice presentation and also for all your work, because the work of the methodologist is a little bit like the intensivist sometimes with our patients. You don't realize how much work there is for the effort that is to bring this to completion. We have time for one quick question. If I don't see anything from the audience, maybe I have one. How can you balance this great methodology with a topic which is very focused sometimes on outcomes that are physiological outcomes and not maybe clinical outcomes like mortality or other?
Yeah, that's indeed that's one of the main problems, and it's a very important question because, as you correctly suggested, several of the studies here and several of the research that has been done in the last decades is on physiological outcomes. And so I have no single clear answer. It's something that we are still also debating on. There is no simple way to do that. We decided to start from main clinical outcomes because that is where you have to start. But then the problem of physiology still remains and should be taken into account.
Thank you, Massimiliano.
Thank you.